like to describe this ongoing transition that we believe is happening. We transition from a nomothetic, grouping people together, looking at averages, that this basic idea is no longer tenable and has reached sort of a limit in terms of how much further we can go. This idea of developing treatment protocols from session to session with specific techniques for a particular syndrome like depression and generalized anxiety disorder and ADHD and so forth, we have come to a natural limit with it. That this is no longer going to be overly meaningful. And we need to go back in a way to our roots. The clinical psychology and psychiatry is in crisis for three reasons. One is as I noted, we focus way too much on protocols for syndromes. We are, in a way, slaves of the DSM, and the DSM, or the ICD, as many of you are also using it, gives us sort of, defines our world, defines the world of pathology. If a problem is in the ICD or DSM, it exists. If it's not in there, it doesn't exist. And we then, as a result, once it's in there, we develop these super specific treatment protocols for all these problems. There's way too little consideration for the individual. Obviously, in clinical practice, we more or less abandon that. We abandon the DSM and ICD code, and we do ask about the individual when trying to get information. Why not just starting out with this idea? Why do we have to pretend like a person has this pure latent disease that needs to be targeted, and then a knowledgeable clinician would easily move beyond these boundaries. So why not systematically examining that? What is it that a good clinician does with an individual? We are way too mechanistic, way too sort of the idea of that there's an input and then there's an output, and everything is linear, and there are certain variables that need to be targeted. Once it's targeted, all is good, and we can fix the problem, and we can send the person back into the system. That's sort of the idea, and that's the wrong idea. So here's the ICD, here's the DSM, and I think this is our problem. We developed these. This is not for you to read, but this is just a snapshot of this ever-expanding list of treatment protocols for all these different syndromes. Who can possibly know all of them? Why is this? Why do we need that? Why do we need such a library? Is our goal here to develop these specialists who only know how to treat disorder X, but not to treat disorder Y? And besides, comorbidity is the norm. It's not the exception, but it's the rule. What you also notice here is obviously CBT is heavily represented, and yes, I'm personally come from a CBT tradition. I'm very much a CBT in my heart and in my soul. I am a CBT therapist. That's my orientation. At the same time, yes, I am one of the people who has been guilty of this situation, because I have contributed to this list. No doubt. I've been developing treatment manuals for treating social anxiety disorder, which is also included in this list of protocols. I think this is the wrong approach, though. CBT is now a very broad tent, and it's probably now no longer meaningful to have sort of this overly specific focus on syndromes. What you also notice is that some of those treatments that have started out as a transdiagnostic approach has become sucked into the protocol for syndromes game. That is the first few here that you can see. Acceptance commitment therapy started out as one treatment for problems, whatever problems there are. And now there have been protocols developed for ACT for depression, ACT for chronic pain, ACT for anxiety. And it's frustrating because we're not moving forward. We're just creating a bigger and bigger problem. None of our students, neither, or let alone us, are able to know all of these ridiculous syndromes.